afternoon and welcome everyone. We're delighted to be here. This is one of our favorite cities in the world, and we're so grateful for the OAC Planning Committee for the opportunity to address you all today on a topic that is near and dear to our hearts. We'd like to introduce the care paradigm for obesity today in our country and give you a little bit of information that we've kind of gleaned working through this process over the years. So here are our disclosures. We've already been introduced, so we can dispense with that. And here are our objectives for today. So we want to take a look at sort of what obesity care looks like right now, and then maybe poke a few holes in that, see what we could be doing better, what things are different or could be different, maybe what it should look like. And then we want to talk about what the impact of this is on a real patient, give you a perspective on that, right? How does that really affect you? So,
thank you. So we're going to be moving around a little bit. I hope that doesn't annoy you too much, but we like to kind of be up and moving around, and we really want you to feel open and welcome you to engage, ask questions, things like that. We'll certainly have question and answers at the end, but anytime you want to interject something, it's not going to throw us off. We really want this to be a conversation with you guys, so by all means, please speak up whenever you feel the urge. So, in contrast to other medical problems that might require some episodic acute care, so you've got bronchitis or a sinus infection, sprained ankle, things like that. You go in, you get it treated, you move past it. We all understand you wouldn't be at this conference if you didn't have some inkling that obesity is a chronic disease and a very complicated disease. And it really does require a multifaceted, long-term approach. So that's what we're going to kind of lay out for you today, and how we might do that better for patients from the start to long-term maintenance. So this just kind of explains what a continuum is. It's pretty common sense, but basically what we're talking about, again, instead of acute episodic care, so we're talking about an integrated system of care that tracks patients over time, involves a comprehensive array of services that really spans all levels. Certainly you guys recognize either it's affected you personally or someone that you know and love and care about. You're going to have different needs at different points in your journey, right? And so what we want to do is lay out that menu of options and what's available or what should be available. And we want you to just kind of be aware of how to find those things moving forward.
I think another point in that is just, what works for one person may not be the right ticket for someone else. We tend to do that. We say, oh, this worked for me, you should try it, right? You've heard that before. Your friend comes to you like, oh, you've got to go do this because this was working and I want you to check that out, right? But looking at medicine and the way we deliver care, and Jenny mentioned about the acute care event, but this whole continuum of care thing already exists, right? There's a lot of our colleagues in other fields that are doing a beautiful job with this, and these are some of our favorite examples. If you have heart disease, chances are you have a cardiologist, right? You're seeing a doctor for your heart. And it may come to a point at which that disease needs an intervention. And the cardiologist and you will decide that based on testing. And then you'll end up maybe with a surgeon. And the surgeon will do a bypass or some sort of operation to help you with your heart. And then they'll get you through that period of time. But then you go back to your cardiologist and you resume that kind of chronic long-term care. It doesn't mean that you were cured of that chronic disease. It just means you had an intervention and you moved from one step to the next to the next. And there was beautiful dovetailing of that healthcare delivery vehicle. Other examples include oncology and also gastroenterology. I really like the oncology one because the point we were making earlier about each person's needs being different, that really kind of resonates with me when we talk about treating cancer. All kinds of different types of cancers with different biology, and we're very specific now in the therapies. And one breast cancer may be treated completely different than another. And so is the case with obesity, right? There's a lot of different factors, and what one person's needs might be completely different from someone else. So this is kind of where we're at, right? we've got this little tug of war going on here, and it's us versus them. Surgeons versus obesity medicine specialists. We're all saying that our treatment is the thing. And that is brought to bear in the literature. You can do a quick search and see countless articles. Bariatric surgery versus non-surgical treatment. Medical weight loss versus bariatric surgery. Surgical versus conventional therapy. Again and again, they roll on and on. You're hard pressed to find many that show a combined effect. And wouldn't it be great if the news were such as we see in the Fantasyland Times, that a landmark study combines the best of both to optimize care for the patients.
USA Someday says the treatment of obesity requires all hands on deck. Surgeons and physicians partner together. What a novel approach, right? To tackle obesity. This is what we want to start to see more of, right? We've got to have examples of this because it really, you will see, I hope by the end of this, you will be convinced that this is indeed what we all need to strive for moving forward.
So what we have here is these two forces that are pulling apart, and who's stuck in the middle? The patient, right? We're getting pulled this way, we're getting pulled that way. And wouldn't it be better if we could all rally around the patient, right? And offer that comprehensive treatment.
And in particular, with this window that popped up in the middle, that core principle that should underlie all obesity treatment, which is coordination of care and long-term follow-up. Okay, so we want to throw this out to you guys. Yourselves, you have a friend, you know of someone who decides, for whatever reason, has an epiphany that they are ready to make changes, they are ready to lose weight. Just throw out some ideas. What do you think that person might do? Anybody got anything?
Would not be asking for treatment.
Sure, ask your doctor. What else? Yes.
Set some SMART goals.
Okay.
Simple, measurable, achievable, realistic, kind
Set goals, I like that. What else? What are some other things? What's one of the first things you might decide to do? New Year's resolution, I want to lose weight. What do I need to do?
Go to the gym.
Somebody said go to the gym.
Go on a diet.
Go on a diet. That's good. So sometimes people are feeling pretty confused, right? Lost. You go on the internet, of course, and you get 1,000,001 best ways, proven effective ways to lose weight. And you're at the grocery store checkout, and right there at the magazine rack, you've got 10 different best ways to lose weight. So it's very overwhelming and confusing. Certainly you guys got it right. Eat less, exercise more, cut back on calories, try to move more. That may work. It may get you some progress. It may work for a little while. Then you may not necessarily see that sustained progress, or you may get frustrated with the rate at which you're losing. So again, you hit the internet. The internet has all the answers, right? And you might see just literally hundreds of different dietary approaches, right? Anybody tried any of these things that are on here? Grapefruit diet, cabbage diet, all liquid diet. Then you might even say, let's step it up a notch. How about that HCG stuff I keep reading about? Or maybe those raspberry ketones that Jack Ross made so famous a few years back. Or there's that, one-time cure-all lipotropic shots that just melt that away. Well, you have to be very, very careful with what you read. As you all know, anyone can become an expert on the internet. We just have to be really careful about what we read. And I like what you said in the beginning. Ideally, we do want people to consider going to their doctor. So let's say you do that. You go to your primary care doc, or maybe you see an endocrinologist or whatever. It doesn't matter. And you say, okay, doc, I'm really ready to do something. Drum roll, what do you guys think that your doctor might say? Anybody? Might get a little bit of this, right? Like, well, I don't know. You certainly, what was that? Read wheel. Okay. You certainly, anyone ever heard this advice? You just need to eat less and exercise more. Anyone? Yeah, that's pretty much across the board. When I do new patient seminars, all hands go up. At some point, some healthcare professional who you have decided to put your trust in and open yourself up, be vulnerable to this person, you're feeling kind of desperate at that point, and you get this simple, Jenny, you just need to eat less and exercise more. Push away from the table, kind of. And you walk out feeling a little defeated, because sometimes it stops there. They don't even give you a handout about how to eat less. What should I follow? It's just eat less, exercise more. So.
Well, and it's hard, before we move on, to from the patient perspective to filter through all that. There's all this mixed messaging out there on advertising, social media, like things Jenny mentioned, and a lot of it is not really well regulated. You know, there's some good regulation with medications and with surgical things, but there's also a lot of stuff that's not. And everybody that is looking to do something about their weight is frustrated. You've tried things, you've spent money and time and effort. Maybe something will work for a little while, and then it quits working, and there's a lot of guilt involved. We blame ourselves when we're not successful. You get discouraged. And so it's really difficult to manage through all that. And even amongst healthcare providers, we are not as educated as a group as we should be, right? I want to give you some insight on a typical surgeon's perspective, right? Just imagine me or somebody like me. Let me tell you guys a little something about surgeons, first of all. All right, this is just between us. But we like to fix stuff. We like to put our hands on something and fix it and call it good. Say, hey, fix that, right? So we take a lot of pride in being able to do things like that. And so this is a very common thing. Examples, appendicitis. You go in there and you operate on an appendix. I can stamp you a guarantee that says 100% sure you'll never get appendicitis ever again. I have cured you of that. All right? But just imagine me operating on someone and trying to stamp them a guarantee that says obesity is never going to be an issue again. It doesn't work that way with chronic illness. But this is how we think about things in general, we being surgeons. We want to check boxes. We've got to figure out analytically, okay, I know this operation is going to help this person. What do I need to get done? All right, body mass index over 40, check. Body mass index over 35 with some comorbidities, also check. Are there any reasons why I shouldn't operate? Are there any underlying diseases or illnesses that might stop me? These are the things we're thinking about. Then I got to get this paid for, right? So I've got to get through the insurance company and we've got to check all those boxes. Do they have benefits? Do they not? All right, say we get past all that. Do the surgery. Surgery done. Yes. Now what? Right? What's going to happen with this patient? I need to keep operating. I'm a surgeon. I like fixing things. What's going to happen to this patient? So this is, you can see the problem sort of developing, right, over time. So in our practice, we take a little bit of a different tack. And what we like to do is think about what the patient's needs are beforehand. What brought them to this point? Why are they different from the person we just saw? What are their successes? What are their failures? We need to ask ourselves if we're ready and if they're ready to take that step. Surgery is an amazing, wonderful, powerful tool, and it can be very instrumental and helpful in a patient's journey. But that's what it is. That's where it stops. It is not the cure. You cannot cut this out. You cannot cut this out. And I think a lot of surgeons think that maybe they can. And if it didn't work the first time, we'll just keep cutting until we get it right. Or maybe someone else did it. It's not as talented as me. I need to take over. Let me get my hands in there and figure that out. We need to understand the disease a little bit better. And that's the philosophical difference that we're going to run through.
So, from an obesity medicine specialist perspective, and first of all, if you guys don't know that term, you're not alone. It's a fairly new field, and it can be a doctor who's in any field who has decided, for whatever reasons, that they want to dedicate more or all, in my case, of their practice to the prevention and treatment of obesity. Lots of continuing education, there's lots of courses out there, and there is a board certification for this as well. We're working towards official medical specialty, but that's going to take a little bit more time. But do know that at least these are folks who've gone above and beyond, because as we mentioned before, unfortunately, traditional medical school training, residency training, most programs, it's really scant in terms of that training. And it's still to this day, where we are with this obesity epidemic, we haven't seen a lot of growth and change in that department. We're working on it behind the scenes, we have a lot of work to do. So from my perspective, when I sit down with that new patient, first and foremost, I want to know what made you change your mind and decide to take action now. What was it? Was there something that happened in your personal life? Sometimes it's a diagnosis, a new diagnosis that happened, or maybe a loved one's life. Maybe they lost a loved one. And some of the reasons for that might have been, obesity-related diseases. But I really want to understand those motivations, and that really helps me see from that patient's perspective why they're there, and we can start to build our plan of attack based on that. We want to understand their pattern of weight gain, starting in childhood, believe it or not. We go way back, and we understand what things were like growing up for them in their environment, some of the traditional patterns, I guess, around eating, around food. Not that this is the only variable, but I want to know, because that's a really powerful tool, the nutrition, as we'll talk about. If were there any major life stressors, perhaps, where you had a more rapid weight gain in a shorter amount of time, and identifying throughout that conversation contributing factors for each and every individual patient. Because, as I'll show you in a minute, all on one slide what those factors are, everyone's going to have a different, the puzzle's going to look differently. I like to describe it this way with patients. You all have a puzzle that overall, it lays out your overall health and wellness, or what we want it to look like. And some people, nutrition may be a big chunk of that puzzle piece, right? And maybe physical activity is smaller because they're already in a good rhythm of physical activity and active. Maybe stress is a big chunk for some individuals, or comorbidities, other illnesses that might predispose them to weight gain. Medications that are required to treat those illnesses. The next point, some medications are extremely weight positive. Sometimes you can't avoid them, but a lot of times, believe it or not, we can. And so just know that there are hundreds, maybe even thousands, but for sure hundreds of medications that are weight positive, meaning they drive your body to gain weight, store fat, slow metabolism. So one of my jobs is to make sure that I go through your history. I'm looking at the medication list, and I'm not going to start changing things willy-nilly, but working and partnering with your other docs to make suggestions. We have a very good training in terms of understanding for depression, for instance. What might be a better choice? Instead of Paxil, let's go with one of these other medications. So that's very important, because you don't want to be starting a new program and then you're still on 5 medicines that predispose you to weight gain, kind of spinning your wheels a little bit. We're going to look, as we go through, we're going to be looking at contraindications. Certainly pharmacotherapy, or meaning anti-obesity medicines, can be a very important tool, just as surgery can. So I'm going through checklists kind of in the back of my head as the person's telling me their story. Does this maybe disqualify them or make them not a good candidate for medicine X, Y, and Z? And then at the end, we have a really good kind of go-to streamlined list of what might be the best option if needed. Not everyone needs medications. And then, all in all, outlining and laying out a framework for success for that individual patient, and what that might look like in terms of frequency of visits, allied health professionals that we may need to bring into the picture right from the get-go, or at least talking about what we have to offer if it turns out we do need something. Sometimes people don't necessarily understand that they might have some issues with emotional eating, but as we start to food journal and really look at things in more depth, it becomes very obvious to that person. I had no idea every time that I got stressed out at work, I was down the hall in the snack bar area reaching for something. So we go through all that. And ultimately trying to form a very strong collaborative relationship with that individual that sets that patient up for a long-term communication and a partnership. This just lays it out in a graphic form, those things that I told you about that can contribute to obesity. Kind of shows you everything that can possibly be in there. There may be some that I missed, but this is pretty comprehensive. And again, everybody's story is a little bit different. But as an obesity medicine specialist, we are highly trained to address each and every one of these problems. So we are going to turn it over to Billy, and he's going to tell you a little bit about his story.
Hi, my name is Billy Klump. To be talking to somebody about my weight journey, I never thought that would happen. Looking at that picture, wow. It's been a journey. Yeah, I've done the cabbage soup diet. I did Jenny Craig, Weight Watchers, the grapefruit diet, you name it. I did it all. And I don't think, any of it was successful. I'd lose 10 pounds, gain 20, lose 20, get right back on to gaining weight back. Back when I was younger, I'm going to start early here. Second, third grade, fourth grade, I used to swim. We had a pool next door. And remember a buddy of mine invited me to go to the lake with his parents. We all went out to the lake and we're swimming. And I remember his dad saying, "Hey, you have your own tube." And it took me a second. He was making fun of my stomach. I just remember that being cruel. Just, they all laughed, and I got out and put my shirt on. It was kind of like, that wasn't great. And that was kind of the start of when I really started keeping track of my weight. My mom did like Weight Watchers. She bought us a doctor's scale. I weighed every day. I still weigh every day. I guess it's just a bad habit I have. But I remember growing up and like being in fifth and sixth grade and playing football for YMCA, and they had a safety issue that you weren't allowed to carry the ball unless you weighed a certain weight or less. And if you weighed over that, they put this big X on your helmet and said that way it let the referee know that the kid carrying the balls cannot have an X. And so I remember I'd diet, and you knew nothing about dieting when I was younger. In my family, a diet to us was instead of having 3 tacos for breakfast, we had 1. Instead of ordering the large pizza, you ordered the small. That was a diet. 2 hamburgers for dinner, you'd have 1. So I would wait, all week. They would do this weigh-in on a Saturday right before the season would start. And so that's the way I would treat it. I'd be like, this is my diet. It's kind of funny that you'd be eating these things. And then all of a sudden, you'd go weigh in on that Saturday and just hope that you didn't get the big X put on your helmet. And 9 times out of 10, I didn't. But that was kind of another reason why I started keeping track of my weight. And that took me into 7th and 8th grade years. I kind of stretched out a little bit. Was not real heavy. I didn't feel like. And then I got to my 9th grade year and weighed like 150 pounds. And sad I know that because I weighed, just like I said, every day I knew what I weighed. And from my freshman year for the next 3 years, all I tried to do was put weight on, because that was the thing. If you were bigger, you were stronger, you would win, playing football. And that went on even into my senior year. But I remember my junior year, I tried out for the baseball team. And the coach gave me my uniform. And we went out, we practiced, and it was like the second practice, and he said, "Hey guys, we're way out of shape, we need to get in shape." And he specifically called me out and called me the Pillsbury Doughboy in front of the whole team. And the next day I quit. One of the sport I love, I quit my junior year. That was tough. And, that was just something that was negative. Don't believe me, my life was not negative always. I'm just bringing up some points that happened. But after high school, I went on to work at UPS. Worked there for a while. I was a delivery driver. And I didn't think I was overweight, but every one of those guys was skinny. So when I'd go deliver, it's like, oh wow, UPS has guys overweight. UPS, you must be a supervisor. You can't be a regular full-time driver. You're too heavy. And so that kind of stuck to me. So then I started, again, with the diets, the cabbage soup and all those fun ones that you would lose 20 and then you'd get off of. Then I made a career decision. I decided I was going to get into the mortgage business. No longer going to be a driver at UPS. And it was a great deal for me. But the problem was that I would go and sit behind a desk all day long, take applications and talk to clients. And actually go to lunch. At UPS, I always took my lunch. But now I had the freedom to go to McDonald's, drive through, and pick up a couple Big Macs and sit in my car and eat them because I didn't want anybody else to see what I was eating. Doing things like that just, caused me to eat. And that was a big weight gain. Sorry, I'm up here with notes. And I was heavy, and my wife is helps do trips, travel agent type deal, and they have conferences every year, far away places. And so we would go get trips to Barcelona or Hawaii, and I hated going. Because the last thing I wanted to do was get on an airplane. Because I didn't want to get the extender, I didn't want to do things, to sit for hours being uncomfortable. And, that just wasn't a way for me to go. One of the things that happened in my life that I think really put a lot of weight on me was my mom passed away. And we were really close. And like I said earlier, we got the scale. We weighed every day together. And I think that was a big time. Instead of me going to substances or drinking or anything like that, my addiction was food. So it would make me feel better in life. If I felt bad, I'd eat. And it just became a habit. That's food was how I coped with things. And then, going through all this, I have kids, and we go, they're involved in sports, and I coach all their sports. I was a baseball coach, football coach, and I never ever, we'd take a team picture, I'd be the one I would try to get out of it, or I never let people take pictures of me because I just didn't want to see it. Because to me, in my mind, I knew I was well overweight, but I didn't realize it until I see a picture and go, wow, that really would be the time. So I never wanted to see pictures. I never wanted anybody to take pictures, and it just seemed, I think we had a hard time finding pictures of me because that was the way I was. But yeah, just growing up, or with my kids growing up, trying to play sports with them and do things, it was great. But as they got older, they started questioning me about stuff. Hey Dad, are you going to be here when I graduate? My oldest son plays college football. Are you going to be able to come to my games? And the one that got me the most is my daughter asked me if I was going to be able to walk her down the aisle when she got married, if I was still going to be here. Well, that hit me hard because I didn't want somebody else replacing me, and that was a tough one. And I remember answering them, oh, of course, always put a smile on my face and going back and thinking about it. But still, even at that time, I knew I was heavy. I just didn't know kind of what's going on. Because going to a doctor meeting, I never thought I was sick. Never wanted to go to the doctor. Did not think I was sick. But I was coaching my younger son's football team, and I remember I started damaging my knee, and I'd go see a knee doctor. He would see me, and I had high blood pressure, and he saw my weight. There was a couple times, but I'd go about every 6 months. It seemed like my knee would act up about every 6 months, and he would fix me, and then I'd get, knee would be good, and the next 6 months I was back. And I think it was about an 8-month period I finally saw him, and he told me, he goes, hey, that's when it kind of hit me that you're sick, man. You need to go get help. And he didn't say it in a rude way. He just said, hey, your blood pressure is this. And it's just, you got to imagine this. If you had water running through pipes that only handle like 120 pounds of pressure, and there's 180 pounds of pressure, something's got to give. Something's got to burst. And your knee, if it, you keep doing the things you're doing. So he was telling me, hey, don't run, don't squat, I was like, basically telling me don't live. And that really got me to think and go back to it. And we were at practice one day, and one of our other coaches had lost a lot of weight. And I looked at him and I said, man, if you can do this, I can do this. Who do you talk to? Who do you go to? And he said, Jenny C. And so that's how I kind of got with Jenny.
We're going to hear more from Billy. Thank you so much for
Oh, yeah.
sharing that, Billy. In a minute, but I wanted to just pause. So he comes to see me wanting help with weight loss. He's ready to make some changes. You can just see some of his initial, we call them biometrics, his weight, body mass index. So in the class 3 category for obesity, 47% body fat. And you can see his cholesterol was okay, but certainly triglycerides were high. His healthy or good cholesterol, that's called HDL, was low. And if you skip to the very bottom, you guys may not be familiar with it, but I really hope that you get familiar with this last test called a fasting insulin. If your doctor's not doing it, I hope that they will ask them to do it, because it's something that can go on for 10 to 15 years before you kind of cross over that line into being a patient with diabetes. So you can have this fasting or excess insulin circulating in your body, driving weight gain and fat storage for, again, decades before. Because sometimes our bodies have a really healthy, adaptive way to put out excess insulin to keep our blood sugars normal. That insulin's doing damage. It's directly causing fat storage and inflammation throughout the body. Contributes to heart disease, the growth of cancers. So the upper limit of normal is 10. Some docs who are even a little bit more strict would say 5 to 7. It shouldn't be any higher than that in the fasting state with no food that you're metabolizing and digesting. So Billy's was almost 5 times that. So he was definitely, and with the high blood pressure, not in a good state of health at that point. This just tells you when he started his medical weight loss journey in January 2014. We did put him on a calorie-restricted diet, but emphasized getting those sugars and starches out of his diet, because that's what drives insulin up. Insulin is the most potent driver of fat storage that our body makes in terms of hormones. We talked about increasing physical activity, optimizing sleep, working on stress management, all these things that y'all saw before on that graphic representation can drive weight gain. We did start him on medicine for blood pressure. We put him on metformin, which treats insulin resistance or high insulin levels. And we did put him on Phentermine, an appetite control medication. So let's hear from Billy about kind of how this worked for him, what he felt like were challenges, what worked, what didn't work, and we'll go from there.
Yeah, in the beginning, Jenny put me on a diet, and boy, right off the bat, we saw some results. The low carbs, the high protein, that seemed to work. I liked it because Phentermine really was an appetite suppressant, and that helped. And getting my blood pressure down, I could tell, I wasn't as anxious at things. And then of course the metformin, I don't know if I probably had diabetes, but that was keeping that down for me as well. But yeah, I think the putting up the diet, getting in the exercise, you can see on that chart that it worked. It came down, and I was rolling there for a while.
And then life happened. So tell us a little bit about that period of time. We'll go back for a second, but kind of you had some success. You kept it off for a while, and
in the November of 2014, my father passed, and on that chart you can see it kind of went, and then I just got stuck again. And I was really close with my parents, and again went into a little bit of depression. Again, my addiction was to go eat. That made me comfortable, that made me happy, and so that's kind of where I went to. Got away from dieting, got away from exercise. Kind of went to a stage where I was like, you know what, I've just got to accept that this is me and this is how I'm going to be the rest of my life, and kind of accept it. And that made it okay for me to do bad things to myself and eat raw and stuff like that. And that was totally...
So what you just said was, everybody's experienced this, right? Where you have a setback or a stressor in life, and it causes a problem, right? If you don't have a healthy way to adapt around it, everybody goes through this. Nobody's weight loss curve looks like a perfect ramp down, right? In best case scenarios, it looks like a stairs where there's a plateau, right? Who's been on a diet or lost weight and hit a plateau? Everybody, right? And who's gained a little weight back for whatever reason. So this is really normal. And it's really important that we understand that, because it's easy to get discouraged. That what he just said to you, that happens not because of that one moment where he had that struggle, but because of a whole lifetime that he opened up to you and shared of just these chronic beatings, like the things people said to him that he shared with you, the things that happened to him, and he just kept bouncing back and bouncing back. But it's very easy to get discouraged, and you get sometimes to that point where you feel, this is just me, I'm just stuck. And that sort of acceptance, and you do sink into that depression. And that's something that's a real thing that has to be treated.
So Billy, can you talk to us a little bit about what maybe got you back in the office, or got you back thinking about what can I do?
I think it was, really seeing where I was at, and, just trying to get motivated to get back into it. Kind of like some of the events I told you, I just wasn't feeling right. I wasn't feeling good about myself, and just decided that, hey, I needed to get back to Jenny and Mickey and see what they could do for me. And the biggest point, and it's kind of funny and it's kind of silly, one of my best friends had a surgery done, and I saw him and didn't recognize him. And this guy was always bigger than me all through high school, and to see him probably 100 pounds, 150 pounds less than I was at that time, I came home that night and said, I'm calling Jenny tomorrow. I got to figure out a way to get back and do this. And really said, hey, wow, this guy did it. I never thought he could have been this. And see him jumping off the walls and all the energy and excitement. It was like, I gotta be there.
Yeah.
So we met and we talked and decided that he did need to reconnect and a different tool to add to what he was already doing. Because you did see he had this very nice dip with what was going on. But then there was this reversion back up, and we decided, the three of us, to add a surgical tool. So we did do a sleeve gastrectomy for him, and then you can see, you can track down that nice graph to, just a couple of weeks ago, where he is now. So adding that, plus what he already knew, has provided him with a good,
87.6 pounds down for Mr. Clark. And notice his curve is still trending down, so we don't know. That's one of the things that, he's right at a year, a little bit past a year, and we'll see that in a minute, but some people, you're gonna hit your nadir in terms of your benefits from surgery somewhere between 9 and 18 months, so we don't know what the future holds. But we certainly are gonna support him in every possible aspect and every way that we can moving forward. This is a picture of, I don't know if you guys know what a DEXA body composition scan, but it's just the most detailed and accurate way that we can assess body composition in a physician's office. There may be some research methods out there that you can do it in some academic centers. And not a lot of doctors' offices have this, but we did invest in this. So if you're not familiar with it, the red shows the densest area of adipose tissue or fat tissue. Yellow is intermediate, and green is the lean tissue. So you can see that he's well on his way to becoming a lean, green fighting machine here. The numbers that you see at the bottom, you're probably not quite familiar with. That VAT word, that stands for visceral, which is kind of another word for organ, adipose, fat tissue. So this is particularly concerning to us. It's that fat tissue that's not just under the skin that you can pinch. That's subcutaneous adipose tissue. This is that fat that's deposited deeper around the heart and the liver and the kidneys in an area called the omentum, which overlies the intestine. It tends to be that fat that acts up, misbehaves, and drives disease. So we are very careful at our practice to monitor this and make sure we're not just affecting the number on the scale, we're fundamentally decreasing this person's risk for disease. We are making them healthier. They are making themselves healthier. We are just guiding them. So pretty cool pictures to see. And then this just shows you his follow-up labs. I just want to highlight a couple of them. Of course, his body mass index has gone from 46.8 to 33.9. Fantastic. Percent body fat, look at that. 47.3 to 30.5. Cholesterol was good in the beginning, still good, but the HDL, that is one that if it's higher, that's better. It protects, right? It provides protection against heart disease. And it went from low at 37 to 70, which is wonderful. So we know his cardiovascular risk has definitely gone way down. And then down at that bottom, remember that number that was nearly 5 times what it should have been, that fasting insulin, look where that is. Rock solid normal. So really exciting, great success. So tell Chris, Billy, a little bit, if you don't mind, about where you are now, what you're doing, what do you feel like's working?
Yeah, one thing I really do want to point out, Mickey was saying this earlier about having the surgery and the tool of that, but not only that, but just having the teamwork of Jenny to kind of keep guiding me in the right direction, to continue to lose weight. I try to cut out as much sugar now as possible. I'm eating healthier and being consistent on things. Every morning I drink a protein shake. It's high protein, low carb, and it's just consistent. So when I go to eat, it's just like a meal supplement, and I love it because I can feel it when I don't have one of those. Just being cautious at lunch. Stay out of the McDonald's line and things that I was doing before. Staying on that low carb in small portions definitely helps. And then exercise. I've had more energy now than I've probably had in 20 years. I feel like I've got my youth back. A lot of people tell me, you look 10 years younger, and I feel it. I really do. It's working, and I'm able to coach my son here, who's 14, coach his baseball team. The other day we went to the beach for the first time in years, and we played out in the water for about 2 hours in the surf. And I said, Parker, when's the last time me and you have actually been in the surf and played out in the water? And he said, Dad, never. This is the first time you've ever been with me, that you were confident enough to get in the water and hang out on the beach with me. Because usually I just sit back and try to stay out of everybody's way. So that I'm no longer taking any medications. definitely the victories, the positives. I got a lot more energy. You know, my wife gets mad at me because I'm out walking and I'm always gone and stuff like that. It used to be I'd sit on the couch and I was always at home. Now I'm out and doing things, so which is great. She's not always mad. That's a joke. The challenges, I will say, have been going back to, hey, you know, Sunday night, let's make some brownies and ice cream and do all the things we used to do. And, you know, I really don't have an interest in it anymore. It's kind of weird that, you know, you go from being so addicted to food is everything, and that if you're got a headache, you go eat. If you're not feeling well, you go eat. That was it. And then my goals are definitely, I think, I don't know if I mentioned, I weighed 210 in high school my junior year, and that's my next goal, is to get back to 210, and I'm almost there. So.
Thanks, Bill.
So, moving back into that global perspective, you know, you want to ask yourself with your journey, what comes next? You're doing an intervention. What comes next? We worry about a honeymoon period or honeymoon phase where peak weight loss can happen, and after a procedure in particular. But what tends to happen with the surgeon follow-up that is troubling here is we start stretching it out, right? Because remember, I got a cut. I got to be in that operating room. So I can't be seeing clinic when I need to be in the operating room. So we stretch our follow-up. It's designed really for failure if you think about it. But a typical follow-up is, hey, we check you 2 weeks post-op, make sure you're healing up good. Bring you back at 6 weeks, then 12 weeks. Then we'll wait a few months. And then we'll hit you up on anniversary. And then maybe once a year after that. When do people start needing that help? I just told you that people hit this honeymoon period and then their peak weight loss will happen between 9 and 18 months. That's the same time that I'm seeing you less and less. The time that you need me most is the time that I'm seeing you least in a typical follow-up regime. So that's a problem, right? So we see this, and this is brought to bear if you look in the literature, right? There's some weight regain that can happen after surgery, right? And the average number would be about 10% of that weight which you lost. The problem with that is that if you look in the literature, really less than a third of the patients who had a surgery are still being seen at all after about 5 years. In fact, we just looked up a study the other day, Jenny and I did, that was done out of UT Southwestern, where they did a large meta-analysis looking at over 7,000 studies of long-term follow-up. Do you know how many studies met criteria for, at the time they were using the one system, one database, would have passed requirements for that? It was less than 3% of the studies. So there was like 26 studies that had acceptable long-term follow-up. And that means people just weren't following up. So there's another paper that shows, well, what's happening with these people that aren't following up? And so they did I forget their words, but they used hyper-intense, aggressive means to chase these people down years later. And it turned out 60% of those people who hadn't followed up had gained a significant portion of their weight back. So it's a problem the way that we're organized here, as you can see, right? We want to know that you are doing well and that you have that structure built in. This is a slide from an article that we pulled from JAMA that shows different subgroups of people. And that orange group at the top is the one I wanted to highlight for you because that's a 10% weight regain, right? There are also some very successful people that are lower, but those people are actually followed up. So there is a risk for that, and we have to be mindful of it. Again, you can't cut this out. It cannot be excised like an appendix. We have to continue to treat with different ways.
Can I just say something here? So remember, this is just looking at average weight regain in those that we are able to track, which we've just established is less than 3% of the practices out there. So there's a lot, there could be potentially a lot more weight regain that we're just not talking about and identifying. And I don't think it has to be that way. If we can build in this more comprehensive approach and consistent and comprehensive follow-up.
And it makes sense too, Jenny, because if you think about what Billy just said about got discouraged, right? He got to that point where he was just accepting that. Well, imagine the feeling a patient would have if they had that happen to them, right? Well, I not only failed all those diets that I tried, but now I've failed surgery too. And that's the thing we have to get our mind around, because we need to validate it that surgery didn't cure the problem. We have to keep finding that this requires more interventions over time. We have to stay on top of that, right? So here's some pitfalls that we've noted, right? There's overconfidence, right? We can believe, oh, I got this, no problem. Especially that's sort of built in during that honeymoon phase, because believe it or not, people can get away with some stuff during this time and still lose weight. Old habits sneaking back into your life. Billy mentioned brownies and ice cream on Sunday, right? Those things are there. They can sneak back in if you're not careful. And you know what? These surgeries become a little bit more forgiving as time goes by. What was really tight during that first few months might not be so tight after a couple of years. I tell people, I think it gives you a little bit of control back. It's really hard on you at first, but slowly it eases you back into where you're in control, right? There's other phenomena which some of the surgeries create, such as dumping syndrome, which is an aversion to sugar. If you eat something sugar or sweet, many of you probably know what this is, that you feel terrible. And that is really profound right after a gastric bypass for most people. But 5 or 10 years later, they can get away with some stuff, not so much, right? So the surgery is sort of losing its power, so to speak, over time. And again, the reason for that is it's not the cure, right? It is a tool. So again, these follow-up protocols have to be different. They're not designed to treat what we normally treat as surgeon, which is acute care things. Acute care, intervention, make sure the patient's okay, high five, you're out of there. The surgeon gets to put on their Superman cape and everything is good. Chronic disease, it ain't working that way, all right? So we also have to look at expectations, right? We have to set some goals, and someone mentioned SMART goals earlier in the talk. I think that's critically important, setting realistic long-term goals and holding each other accountable. As part of the care team for you or whoever my patient might be, I want to be held accountable as well. We need to provide that structure and support. I tell people, hey, if you're struggling and it's not time for your appointment, you give me a call, shoot me an email, we'll get you in here, we'll get it figured out, right? So that brings up a topic in talking about maintenance versus weight loss, right? Those are two different things. Maintenance implies you've gotten to your goal or somewhere near there and you just want to keep it straight, maintain it, right? Completely different than weight regain or loss.
I want to just add one thing to what he said about patients feeling like sometimes not following up because maybe there has been some weight regain, and I've heard people tell me this. I was embarrassed. I felt like a failure.
Yeah.
Let me just be the first to stand up here and say that it is not you that has failed. It is our system that has failed you. So you just exhale, let that tension out, and know that we are not doing the best for patients right now. And we're working hard to make it better, but please let go of that guilt that you have somehow, induced this failure. We have not done our job in terms of engaging you in the right ways that you need, that may be different from what you need to make this long-term successful. Oh, so we're going to talk, sorry, this is my slide too. There are some things, certainly, so you've lost some weight, you want to keep it off. There's a great study that I'm not real excited sometimes about some of the things that our government does in terms of their involvement with nutrition. This one I actually like. So it's called the National Weight Control Registry, and it basically tracks over 10,000 folks who kept at least 10% of their weight off for at least 5 years. What are they doing different than the rest of us that are kind of yo-yoing and going back and forth? And this is not just surgery, this is all comers, any way that they lost weight. 98%, nearly 100% changed what they ate. That is crucial. So you really got to have a very strong understanding about nutrition and how it interacts with your body. They have increased physical activity. And it may not be crucial in those early months, but absolutely it's something we're going to gently nudge people along to become more and more active as they go through their journey. Eating breakfast, we talked about the exercise part, and on average 90% of them are exercising an hour a day. That might sound shocking, like a lot. Remember, exercise is one way to talk about it, but we're just talking about moving, right? We are just limiting sedentary behavior. So I like to use physical activity rather than exercise, because some of our jobs, I mean, people are going nonstop all day long. Count it. It absolutely counts. Okay, and then of course limiting sedentary behavior activities outside of just desk work and things like that, but watching TV, computer time, staying engaged with that phone. So those are important things, and I think we all need to take note of those. These are some really important goals that we need to kind of set some parameters around and try to stick to. We need to work together to figure out what should your goal look like. A lot of people ask this because it drives my patients crazy when we print out their body composition using a different tool called an impedance, and it always prints at the bottom that horrible word that I can't stand, or phrase, ideal body weight. I mean, there's healthy body weight, right? And I think we need to look at the way we're talking about that. So we drill down on body fat, disease processes, and all kinds of other measurements that show success and progress, and kind of go by those. But just having some built-in checks with yourself. How are those favorite jeans fitting? Or that favorite black dress that we women like to wear sometimes? How are things feeling? How are we feeling in terms of being comfortable in our own skin? As well as, of course, getting labs monitored periodically and all those things. We need to establish some safety. There's 5-10 pounds weight gain. Do some self-correction. It works, great. But if it doesn't, you get back into your support circle, right? So that it's much easier to take that off rather than, you feel bad about going in. Maybe you're in an environment where they're not very welcoming for you to come back in because they're overwhelmed. You got to find somebody else. But get back in because it's much easier to get on track. All right. See you. Weight regain.
Yeah, so again, I mentioned before we're trying to distinguish between a maintenance program and a regain situation. But the first key, if you do experience some regain, is obviously look at the nutrition, the diet. That's critically important. And what might have worked before may not work this time. I mean, has anybody done a diet that worked really good once and then the second time you went through, it was like, your body was like, I don't know about that one, right? So that's really common, right? You have to address behavioral concerns or issues, emotional eating, again, that's sedentary behavior stuff, and then look to add anti-obesity medications if indicated, right? We use these tactics quite a bit in conjunction with one another. But we need to increase support. As I mentioned before, it tends to be with the surgical arm, we're seeing people less and less, right, when they need to be seen more and more. So we have to add these things in. Obesity medicine specialists, health coaches, counselors, dietitians, fitness trainers, and this comes in many different packages you'll see later. But then we can also consider, is there a technical problem with the surgery or something we can do a little bit better? So I want to talk to you a little bit about our vision. First of all, it's never as good as the first time, and it's always more risky. So we have to take it on for very specific reasons for very specific people. So as a surgeon, you might ask me, well, how would you determine if one was indicated? Well, the first thing is we need to look at the anatomy to see if it's still like it's supposed to be. The body changes, it adapts, and things can change, which may not have been a part of the original surgery. You can get dilations or communications that shouldn't be there between two different systems, and that's a technical failure. It's never going to work in its current format, so there needs to be something different. Then we need to decide if there's a true medical necessity to fix that. Is this thing messed up and causing a symptom or a problem? Or is there just simply a weight loss issue? Will this be helpful to the patient, right? I can do a revision technically, but is it really going to benefit someone? If they already have a very small pouch, maybe 30 cc's, and I make it 20, is that going to help them? I don't know. I don't think so. So we have to figure out what's right and what's not right. And again,
I was just going to add, in our practice, this isn't true across the nation, but we feel strongly that it should be. Somebody comes in, a lot of times when patients have weight regain, of course that's one of the thoughts is, do I need a revision? Is there something wrong with the way they did the surgery? But we like to put the brakes on, and really we funnel those patients over to me. I go through all those different aspects that we talked about, stress and where they are emotionally, what they're eating, all that kind of stuff, before we would go back in and do this high-risk procedure that doesn't necessarily get that patient a lot of extra gain. And a lot of times we're able to avert doing a revision. We get them back on track and we see that curve go down even further, sometimes even lower than they got with their original surgery.
That's right.
Because again, we put the whole puzzle piece together. All right. So this is a slide that just kind of lays out what we feel like the obesity care continuum should look like. So you've got there's different categories, right? There's overweight, 25 to 29, and then varying degrees of obesity. We refer to as class 1, 2, and 3 across the top. And we really feel like that whole nutritional aspect, physical activity, behavioral modification, and the option for medications should be offered across the board, right? For all folks, and ongoing through this entire journey. That's not the case, again, for lots of folks, but we really want to see this change. That's what we're working towards. We can offer endoluminal procedures, which you can touch on if you'd like, but just know that those are those kind of not quite surgical procedures, but minimally invasive techniques that surgeons usually do, balloons and things like that. But that's a pretty narrow window in terms of what the FDA has determined the patient population should be considered for. Does that make sense? So only for patients who have a body mass index of 35 to 39 with comorbidities is that FDA approved, correct?
Yeah,
So,
it depends on the device, but yeah, that's.
And then, of course, surgical procedures. And there are outliers, we know that, and certainly our surgeons too. They operate outside of those FDA formal recommendations because they are really fundamentally focused on that patient sitting across from them. So someone who's very sick with diabetes, kidney failure, they need a transplant, and their body mass index is 32. They are absolutely not going to just say, sorry, you don't meet the criteria. I think that's important that you have a surgeon that has a little bit of an open mind to that. Bariatric surgery procedures being 35 to 40 with a comorbidity or greater than 40. And then I think that last row there is important because it helps you understand that if we only used surgery, you would potentially only be talking about, about 14% of folks, right? That potentially, could benefit. Now of those, I think the number is about 1% who actually end up getting surgery. So we're really affecting a very small percentage of the population. It's also just makes common sense that we need to really be using all hands on deck and addressing this in a more comprehensive way. Anything you want to add on that?
No. Good. So instead of those two arrows which were pulling the patient apart right now we want to team up and hone in on the patient's needs, right? So there's different models for this. I mentioned this earlier. That could come under one roof. Like our practice, everything's sort of right there. But there can be referrals and different practices at even different locations. As long as they're working together and everyone is communicating well, this can look many different ways. So you've heard all of this. Like, why aren't we doing this, right? We mentioned the analogy in other branches of medicine. We think that there's a lot of problems, and we're going to talk about some of that stuff. There's a lack of awareness about the emerging field of obesity medicine. And more so, and probably most importantly, there's this perception of competition, right? Like that tug of war slide from the beginning, it's us versus them instead of us and them. And then there's this failure to recognize and validate one another. I think these are major issues that are stumbling blocks. From a surgeon's perspective, if I'm in my surgical practice and I spend money, educating the public or, working to try to get patients into my office, I don't want her stealing them and doing medical weight loss on them. I don't have anybody to operate on. That's what I'd be thinking, right? So maybe I just do this myself, or I'll just call my follow-up comprehensive care. That's what I'll call it, even though I don't have the ability to see this patient after a year, except for once every year when they need me most, I'm there least. So you can see how these things really don't work, right? Plus, most surgeons think they are curing the disease still. So there's just a lack of education about the treatment of the disease and all the approaches and how they can work together.
And from an obesity medicine specialist perspective, we're still struggling with validation in terms of being a recognized area or focused practice. We've got a lot of work to do there, but it's hard. I don't know if you guys have come across obesity medicine specialists in your community. We're going to show you later on just quick little ways that you can identify those folks, some shortcuts to finding them. And we're working to try to partner up surgeons with obesity medicine specialists on a broader scale, trying to develop a program where we can do that. Again, that stereotype, many of my colleagues, I've heard them at many of our conferences talk about, oh, those surgeons, they just want to cut and run. They just want that money and they're done. And that I know from knowing not just my own husband, but many surgeons from attending lots of his conferences, that's not necessarily the case. There may be some like that, but there also may be some obesity medicine specialists, which really kind of looks like one of those quick doc in the box, pill mill type systems, but they're calling themselves obesity medicine specialists. Be wary. I showed you all those things that should be addressed by an obesity medicine specialist. So if you're walking into a clinic, they're writing you a prescription, maybe handing you a piece of paper with some nutrition recommendations, and you're in and out in 5-10 minutes, please find someone else, because they're not doing you any good there. Some of my colleagues are worried that they're going to just be the surgeon's assistant, checking labs, those post-op malabsorptive vitamin levels and all that stuff that we have to follow post-op. And that actually has happened for some of my colleagues. But I think we're seeing less and less in that, and we're seeing a little bit more of a collaboration and understanding what we can each bring to the table. Let's see, let's move ahead, because we want time for questions for sure. Do you want to talk about that?
Yeah, so just, again, barriers are cost, availability, recognizing this problem. It wasn't until 2013 that we even called this a disease, right? The AMA called it a disease in 2013. So only for 4 years are we even treating a disease. There's, again, this disconnect and bias and stigma. So we're going to talk through a couple of those things. One of the most important one, though, in our mind is the stigma. Why is insurance coverage so rotten? Why do we not have coverage for this? Is it because people think that it's a character flaw? I think there's something to that, right? People don't understand the disease. Many people within the healthcare ranks don't put it on the same pedestal as heart disease or other major problems, even though it kills many people every year, right? And the public is not being educated about it, and we're not talking about it in the media. Everybody hear about the opioid crisis, right? Yesterday, our president declared it a national emergency. Just a little quick tidbit about this. Opioid crisis, $55 billion a year. Obesity, $1.4 trillion a year. That's 750 times more the cost of the opioid crisis, okay? And it's way more deadly.
We're not saying the opioid crisis isn't important and significant. We don't need to sound like that. But we're just saying, where is all the attention that obesity really deserves and requires? I really like to talk about my job. I mean, I think I have, first of all, the greatest job on earth. Just want to say that. It is so fun to be part of individuals' journeys towards a healthier, more robust, and full life. But we talk about not just treating the comorbidities, right? And that's what I did before as a primary care doc. Now, I get to get at the root cause. I get to fundamentally help that patient put themselves on a different path, right? We get to see medications fall away. Oh, sleep apnea is gone, blood pressure is better, cholesterol is down, diabetes is in remission. I mean, it's absolutely fascinating. Why did insurance companies not want to treat this root cause, but yet are willing to pay, not just for the medications, right? Because we're talking about cardiovascular surgery, even cancers that are driven by obesity. They fully pay for all of these other things, but not for someone to come and see somebody like me or have surgery. It doesn't make any sense, and we need folks to speak up about this.
So we have a PR group that we work with, and what we did was they ran data through this special program to see how many news stories there were over this period, which was, I believe, 90 days, right? Well, twice as many news stories on opioids as were on obesity, right? So what needs to be done on a bigger stage? We've got to increase the education for healthcare providers and everybody. We need to understand and recognize this is a disease that has valid and real treatments which are successful. And we've got to work better together. We've got to go hand in hand to the legislature and say, look, we can help. We need to fix this. We need to pay attention to it. Our societies need to get together more. We need to align ourselves, have one unified voice advocating for access to care and better care. We need more research, we need more dollars, we need more attention put for this. We need legislative efforts. We need a large-scale public awareness campaign. I remember all those ones from the 80s were so great, like this is your brain on drugs with the egg. We need something cool like that, you know? We need people paying attention to this.
As well as not just the significance of obesity, but destigmatizing, I think, also. Helping people, you know, develop some empathy about this. So these are just some websites that you can take action yourself if you so choose to. As simple as writing an email and they pre-format it for you. You can send it to your friends who can all send it, and it will drill down to your local legislators, which is fantastic. And this is an OAC thing that has put this together, so kudos to them. But they make it super simple. But we absolutely need a grassroots effort. We need everybody on board. Some other ways that you can find ways to reach out that are, again, they do all the work for you. You just kind of put in your name and put some details, and away it goes. This is just a few slides, and then we're going to wrap up here of how to find a clinician. So this is from the American Board of Obesity Medicine. This is what the search page looks like. You can put in your area, and voila, you get this whole list of folks who at least taken that extra time. We can't say for sure that they are, you know, the best in the area, because there are people that haven't taken this exam but practice excellent obesity medicine. But this is definitely, the fact that they've gone through all this trouble, it speaks volumes to their dedication, I think, to the field. So, and then this is the Obesity Medicine Association, which I'm kind of involved in, also has another Find a Clinician source for you there, as well as other patient materials. ASMES, how to find a surgeon, and hopefully, like I said, we're working on that how to find a collaborative team sort of search tool down the road as well. So, thank you guys for your attention. We are going to turn it over to the highlight of this talk, which is Billy, and he's going to kind of finish things off for us, and then we'll do some question and answer.
Yeah, just real quick, I think y'all heard me earlier. My daughter asked me if I was going to be around. The picture was from about 2.5 weeks ago. I was walking her down the aisle, so yes, the answer to that was yes. Yeah, you know, for me, it's been a life-changing experience, no doubt. And if you do decide, you know, to do something, take action early. I wish I'd have done this 10 years ago. I really feel like I lost a lot of my life when I could have done it earlier. So if you're thinking about it, definitely I would take action immediately, even if it's just a phone call or just getting some consultation. And if you're going to do either a surgery or something, make sure you get with a team like this, somebody that's not only going to just do that for you, but they're going to continue to follow up and to care. I've built a relationship with both of them that you know, just it blows my mind that how much they care for you and how well they want to see you succeed. And if you do decide to go to the next step or do that, or you make sure you find somebody like that, because I think, like they were saying, everybody's being pulled apart. When you're taking my patient, and when you see people come together and they both care about you and do something, it just makes you, one, not want to disappoint them and be successful, but two, it's just encouraging to have a team like that together.
Thanks, Billy. So, any questions?
Throw out anything, questions for Billy, for me, for Nikki.
Over the mic. I don't want to teach your voice anymore. Hi guys, thanks so much for an awesome presentation. I would say to Billy, as a daughter of someone who has said to her dad, I might get it choked up, said, I want you to walk me down the aisle. Thank you for listening to your kids. So that is like, dads are stubborn, so sometimes, and And we often see a lot of women on stage, to be honest. So I find your perspective really refreshing. So thanks for being here and being brave with us. So my question's for Ginny Seeger. What do you advise patients who I'll use myself as an example. I'm a post-bariatric. I actually had a revision. I had a failure in my lap band and revised. So 120 pounds below my high weight, but 50 pounds above the lowest weight I ever achieved. And chronic stress is something that I deal with. I have a really high pressure job. What's your best advice for dealing with stress when you know that's like, people need to keep their jobs and have a family, and also like it's hard to like know where to start. So
that's a great question. I think stress is a huge factor that we sometimes don't really want to, come to grips with or fully embrace that might be one of our struggles. Understand, we talked about insulin being a big driver of fat storage. Well, cortisol is our major stress hormone, so it also is potentially a big driver of fat storage. So I always, kind of figure out what are the major stressors. We actually do a little exercise where patients will write down what are your stressors. Big, small, things that you think are just so ridiculous, but they're on the list. Everybody else might laugh if they knew it. This is for your eyes only, but it's for you to just take stock in those stressors. There's things on that list that you can do zero about, sadly. Like for mine, I think about terrorism, I think about that nuclear threat stuff. I can pray, that's about all in my job, that's about all as far as it goes. So you got to kind of look at your stressors and say, what do I have direct control over? Or some potential, some way that I can impact it directly. Because those other things, we have to figure out healthy coping mechanisms to just cope with those and to settle in. Prayer, meditation, exercise, all the different healthy tools that we know of, professional help and counseling, support groups. So those can be very helpful as well. To know that you're not alone with carrying some of this stress, but we have to learn how to kind of deal with them in a healthy way, make sure we're not doing things that are harmful to our body in terms of coping. Sometimes medications can help. If it's to the point where it's caused some anxiety or some depression, we need to own that and address it and not think of it again as a weakness. The fact that you're getting help is going to help step you towards progress. And we address that at every single visit. We have a little thing that says, rate your stress level. Is it 0, happy as a lark, or 10, I'm about to jump off the cliff? And nothing like it. It doesn't say that, but we really want to know at every visit, how are you feeling? Because if somebody's chronically up here, we're going to spend a lot more time talking about that. And a lot of times engage them. We have our own in-house behavioral health specialist. If that doesn't work, we look at their insurance and try to find somebody in their plan. So
I appreciate it. Thank you so much.
Thank you for the question. Anything else we got?
For the morbidly obese patient that is not able to get to your office.
Well, if we somehow are made aware, like we do have people who will email us and they found us and maybe they geographically can't make it in or their insurance doesn't cover it, and we're going to try everything we can to make that work financially for that person or to find someone. And that's the beauty of both of us being active in our organizations. We're well connected all around the U.S. to find another team that might be similar to be able to get that person help in their geographic region. But we do what we can. And even our dietitians, I have to say, which is, of course, cost-wise, much more doable for many people, are amazing. They're almost more life coaches than just dietitians or dual. And so we would work with them as well. But we're pretty resourceful at doing anything and everything that we can to work with the insurances. We write personal letters. We do those things called doc-to-doc reviews where he gets on the phone pleading with the insurance for why this patient might need our care. And we just had something come up recently where this insurance provider, it's a local one in Texas, said one of our other surgeons wanted to do a revision on someone and they said, well, the only way this will happen is if they're doing behavioral modification, all this stuff, the non-surgical stuff. And he could very easily say, well, you know what, they've already been doing that. And so what they said was, send us that data and let's talk about it. But the next cool question was, who would like to meet that person? And what does that look like? Because they don't know anyone else doing those things. So I don't know if that answers your question. I mean, we are doing our best to try to improve access to care, like I said, in lots of different ways. through legislation and directly communicating with employers and insurance carriers to try to help them understand there's so much more we could be doing, to help your employees and to help our citizens. Does that help at all answer your question?
I was more talking about physically.
Oh, we do transports, if that's what you mean. Like, not to, is that what you, I'm not sure if that's what you're talking about.
Sort of
Yeah,
like that.
yeah, absolutely.
Somebody who is 600 pounds.
Bedridden, sure, or can't get out of the house. Absolutely, we've had hospital transports. It doesn't happen often, but we do work hard to arrange that, and we sure have done that. Sometimes, too, patients can be admitted to the hospital and kind of get that full-on team approach, that way as well. I think it's complicated. I'll be the first to say it, but absolutely, there's ways that we can get people into the office for that. You have to have a team that's really willing to go that extra mile. Though. A lot of phone calls involved.
Is there a team like y'all here in the city?
Do you know?
There are some very good practices here in New Orleans that I can give you some names, and I'll chat you up afterwards. Yeah.
Yes.
So I think he had one more question. We were out of time, so this is gonna be the last one. If you have one that you didn't get asked, we'll hang out. You guys can talk.
I promise I'll be brief. Let me just say, my name is Tim Clark. I work for AZI. We make Belvique, so that's my. I want to let folks know that. Thank you for your courage in coming up here and sharing your story. I think it was really inspirational. It's really more of a comment. Thank you for highlighting the policy challenges that obesity faces. I am the lead lobbyist for the company. I spend all my time beating my head against the wall on these kind of policy issues. So there are people out there trying to help, and I think the government can help drag employers and insurers down the road. CMS has a tendency to drive practice. One thing I would say is your stories are important. We talked about in the advocacy training how important it is. They are critically important. If you haven't, reach out to your members, reach out to your congresspeople, and let them know the challenges you face. I think the point about root cause is the best point that we've made so far. We talk about, all the diseases that the government pays for, all the comorbid conditions that we pay for. We don't deal with the underlying conditions. So I would urge everybody, and thank you for bringing that up. Thank you for creating a program that I think really is wonderful, and thank you for your courage. And please go out there and talk to your members. Help me, right? So they look at me, I'm just a drug lobbyist, right? But you're real people. I'm not a real person. That story will resonate and will help drive this change, because that's what we need to do. So thank you.
And thank you for
I was going to say thank you for that. We spent a lot of time, Jenny and I, in Texas this year, introducing some legislation at the state level that was started off as a mandate for care, and it quickly got cut and scaled back. But we got that through the House, and then it failed in the Senate.
100% approval in the House. And then it goes to the Senate committee where it has to be voted on first. And this is just a perfect example of how politics work. One person, who is the committee chair, has the ability to decide before anybody else in the committee hears it, whether it's going to be heard or not. And that one person shot it down. He didn't even get a chance to talk about it to the group.
It got sent to the Business and Commerce Committee and not Health and not Insurance. And so it had some real powerful lobbies against it from Texas Association of Businesses and Texas Association of Health Plans. And so they spoke to the chairman, and he didn't put it on the agenda. So, but that's how it works. That's the game. And we're going to try again. We only meet every 2 years, but we're not giving up. And we encourage you all, as Tim mentioned, to please, your part is not insignificant. So thank you all very much for your time.
Enjoy the rest of your conference.
Yeah.
It's a wonderful conference. We sure appreciate you coming. Thank you so much.